10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
This is Dr. Tommy Anelli, and this is the CROC Podcast. Howdy, Crockers. Good afternoon. It's another beautiful Wednesday afternoon. Sitting to my left, Angel Santana, the greatest podcast professor in the universe. Angel, happy afternoon.
Woohoo! The sun is out. The baseball season's up. I'm happy.
You should be happy. Life is good, and life is going to be great for our survivors because we have the second portion of our surveillance module today, and I have a surprise for you.
Oh, I like surprises.
Yep. Ask me if we have a guest today.
Do you have a guest today? Do we have a guest today?
We do not have a guest today.
Oh.
We have two guests today.
And you're telling me this now?
I'm telling you right now.
Aren't I your producer?
You're my producer, but you're also someone I like to surprise. I'm a big surprise guy.
I got to get ready.
You must get ready.
Okay.
So let's talk a little bit about surveillance, and let's talk a little bit about the two gentlemen that'll be joining us today on the CROC Podcast. So everybody knows, if you listened to our podcast last week, which was absolutely mandatory, you heard about colon rectal cancer surveillance with colonoscopy. You heard about my personal experience with colonoscopy number 3. And Angel, I officially got my results. Everything is clean.
Mm-hmm.
A couple of tubular adenomas, but all is good. Dr. Crone was very happy, and I don't have to go back for the happy juice for another 3 years. And then I thought to myself, well, we're ending the Defining Survivorship module. We did a surveillance module while we were killing some time waiting for this interview with Dr. Shapiro, which you guys should have heard already last week. And I'm thinking to myself, well, why don't we continue doing a little surveillance? And this week we're going to be talking specifically to the guys. Gals, you listen in too, because if you have a partner who's a male, this pertains to you. If you have a partner who's a prostate or bladder cancer survivor, this definitely will appeal to you. And we're going to talk a little bit about prostate cancer survivorship and surveillance. I should say surveillance rather than survivorship. And we have two staff urologists whom I respect and admire very much. And I have to tell you, did you ever see the movie Blades of Glory?
I have not.
Oh man,
I gotta
not.
Watch it tonight now.
You're fired. Do not come back until you've seen every Will Ferrell movie available. Blades of Glory is a funny movie. Will Ferrell and there was another gentleman, I forgot his name, the guy from Napoleon Dynamite. They play two male figure skaters that are forced to do. What would you say, doubles, for certain reasons. You'll have to see the movie. And one is a very elegant skater, a very, very refined skater. Technique is perfect. And then there's this hellion, crazy, wild man who is played by Will Ferrell, right? So I'm not trying to tell you that Dr. Michael Hoffman is that wild, crazy guy, nor I'm trying to tell you that Dr. Abourbih is that other guy, but they remind me of Fire and Ice. They're very, very different. Skilled surgeons, of course, wonderful men, amazing colleagues, but certainly very different. Mike's more like me. Mike lets his emotions out on his sleeve. Everybody knows when Mike's in a good mood, when Mike's in a bad mood. And then you have Dr. Abourbih, Sam, who's a little more, he's very, very elegant. He's young, he's handsome. Not that, Mike, not that you're not young and handsome, but you're not as young and handsome as Sam, okay? I'm just going to be straight out. And listen, nor is Angel or I. I mean, it just is what it is, I'm going to be honest. Let's talk a little bit about Mike Hoffman, since I sort of put him a little bit in the hot seat. So Mike is a board certified urologist. He is a part of our Garnet Health medical system urologist. He's been with us. We're very honored and lucky to have him. I love working with him. He did his medical school at Mount Sinai, wonderful school. He did his residency in Valhalla in Westchester, and he did his general surgery in New York City. There are two, and of course, publications, memberships, board certifications, the whole 9 yards. And what really is quite interesting with him is that he loves a lot of things outside of medicine. He is a very, very well-rounded guy. He likes to bike. He likes to photograph. He likes to brew kombucha. He's very, very family-oriented. And there's another thing you probably don't know about Dr. Michael Hoffman. He also owns a food truck that specializes in sourdough bread. And let me tell you something. He is such a good guy. He has done a lot of community events. He has donated many meals during this coronavirus pandemic through his food truck. And I have a feeling his food truck is going to be a big deal. So we might interview him one day when he becomes like this really famous, like top chef sourdough bread food truck, maven, But for now, we're going to talk about prostate cancer surveillance. Dr. Sam Abourbih is a very wonderful young man. He actually is our chairman here in the genitourinary cancer program. He hails from the beautiful country of Canada. We should ask him a little bit about who he likes in hockey, probably the Canadians, because he did a lot of his training at McGill University, which is one of the top medical systems in Canada, if not in the world, right? He did his fellowship at Loma Linda in California. He did a fellowship in endourology, which is basically what poor Angel is going to have to do. Get that scope placed, where you're going to place that scope where.
Ouch.
Exactly. Again, board certified, professional societies, too numerous to count, and actually has a lot of awards and a lot of publications for such a young man. So it is our true honor and privilege to have Doctors Fire and Ice here today to talk about PSA, rectal exams. Ouch, you're going to put your finger where? It is going to be actually a great podcast. And at the end of the day, we're not going to be talking about treatment selections at this point in this podcast. We're just going to be talking about prostate cancer screening. So let's take a little break, Angel. Let's get ready for Doctors Fire and Ice, and let's see you on the other side.
4, 3, 2, 1.
Welcome back, CROC Nation. I am joined, as promised, by the two probably handsomest, smartest, most skilled urological surgeons that I know, at least in this room right now. We have Dr. Michael Hoffman, Dr. Samuel Abourbih, and we are pleased as punch to have you guys here to talk about prostate cancer screening. Just as an aside, I basically use this analogy to all my patients when we're talking about prostate cancer. My analogy is, when God designed the prostate gland, I think he took the day off and he had his second in command, Charlie, who was drunk on the job, because there is not a worse location you can think of. The prostate is basically riding the rectum like a saddle over a horse, and then right above it is the bladder, and basically tunneling through it is the urethra, which is the peeing tube. And here you go, having a cancer of this delicate sex organ. And oh my God, there is so much potential issue there, for sure. Doctors, welcome. Michael, Sam, it's a pleasure to have you. We're talking about a very sensitive issue today for men, prostate cancer. But what I'm hoping we could derive today for our cancer survivor group, for our CROC Nation, as Angel and I like to call them, is some clarity as it comes to a person who may not have prostate cancer, might have prostate cancer history in their family, or might be a young man getting into their stride in their 40s, and their primary care doctor says, okay, guy, it's time to get your first PSA test, and that comes back abnormal. So then all the warning bells, the red flags come up, and all of a sudden life is over. So I kind of wanted to talk about prostate cancer in general, numbers, demographics, that type of thing, and then talk about how we can help our constituency advocate for themselves to check themselves for prostate cancer, how to go through screening, how to interface with your urologist, primary care physician, and just the basic holding their hand through that terrible time called the biopsy. So Sam, let's start with you.
Sure. Great to be here. So we when we see men in our clinic who are interested in prostate cancer screening, there are many things we take into account. Okay, first of all, we want to find out, as you mentioned, Tom, Dr. Gianelli, what is your family history? And you mentioned, family history. You think family history of prostate cancer, but now we're finding that there are links to other types of prostate cancer, such as breast cancer, certain types of colon cancer, pancreas cancer. So prostate cancer does play an important role in determining someone's risk based on family history, but now we have to expand that and look at other types of cancers as well. In addition, we know there are other risk factors for prostate cancer. Certainly certain races and ethnic backgrounds that are more at risk, not only for being diagnosed with prostate cancer, but having a more aggressive type of prostate cancer. So if you have an African American background, you are more likely to be diagnosed with prostate cancer and more likely to have a more aggressive form of prostate cancer. And that is extremely important when counseling a patient. And certainly as we progress in our lives, the risk of prostate cancer increases, much like other cancers. In fact, studies have shown that if you take all men that pass away from any cause, who are age 80 or above, if you were to do an autopsy on these men and look at their prostates, around 50%, up to 50% of them may have some element of prostate cancer in their glands. That doesn't mean that it was a cause of their death by any means, or that even it affected them in any way. But prostate cancer is very prevalent and will increase in age as you get older. So about 1 in 7 men is the statistic that we hear about that are diagnosed with prostate cancer in their lifetime. And about 1 in 30 will end up succumbing to prostate cancer.
Yeah, Mike, jump in.
I was just looking up because we wanted to talk about the statistics for prostate cancer. So according to the American Cancer Society, 248,000 cases of prostate cancer newly diagnosed this year, 34,000 deaths from prostate cancer, 1 in 8 men will be diagnosed with prostate cancer during their lifetime, second leading cancer causer of death in men, behind lung cancer. About 1 man in every 41 men will die of prostate cancer. Prostate cancer can be a serious disease, but most men diagnosed with prostate cancer do not die from it. More than 3 million men in the United States who have been diagnosed with prostate cancer at some point in their life are still alive today. So that really is where the big, it causes death for sure, but 250,000 people diagnosed with it annually, while 34,000 people die from it annually. So, screening for a disease that a lot of people get diagnosed from, but only a smaller percentage of those men who are diagnosed with it, 1 in 8, you can probably speak, Tom, to the statistics for other cancers that you deal with. I mean, how many people who get pancreatic cancer die of pancreatic cancer? How many people who get lung cancer die of lung cancer? Breast cancer, probably a little different. You get screened a little early. So, a lot of people diagnosed, not as many people die from it. How do you appropriately counsel a patient as to what you were alluding to, and that it's a very sensitive location in a man's body and play a very important role in a man's life. And so how do you manage quality of life and not sacrifice quality of life? And how do you, tease out who has who is one of those 8 men, or which man should be treated in order to avoid being one of those? And what's the right treatment, or how do you screen, or how do you deal with that? And because of these statistics of the 250,000 people who were diagnosed, but only 34,000 people who were passed from it, there's been a lot of pushback from society about PSA screening and prostate cancer screening, because ultimately sometimes the pill is worse than the poison, and so getting treated for prostate cancer can have an immediate dramatic impact on your quality of life, and those impacts can stay with you for a long time. While there's a very reasonable chance that cancer was never going to have any sense of causing anything to you other than some number on a paper. So how do you appropriately figure out who is the person that should be treated, and how do you treat them with what they need, as opposed to throwing the book at them? Those are all important aspects of your conversation with your urologist.
Yeah, that's beautifully said from both of you guys. It actually brings up a very fair point. And having some gray hair, more gray hair than anybody in this room, I remember the days when this wasn't so. Prostate cancer was an advanced disease when I first started back in the 70s and 80s. There was no such thing as PSA, and most everyone, they were in the days, guys, when we didn't even have stage 1, 2, 3, and 4. We had stage A, B, and C, and stage D, and mostly everybody was stage C or D, and hormonal blockade was an orchiectomy. So we've come a long way from, a guy coming in and saying, I have some bone pain, and then being diagnosed with prostate cancer. And now, to your point, we're bringing people in much earlier, much younger, just by virtue of a blood test. Sam, tell us a little bit about the PSA test.
Sure. That's actually a very controversial topic. And it's interesting that you say that when you first started out, people were presenting later in the disease course with less treatment options. And so the pendulum was way on one side, perhaps in the 70s and 80s. Certainly it swung more towards earlier detection in the 90s and 2000s with the widespread use of PSA testing.
What exactly is PSA?
So PSA stands for prostate-specific antigen. It is a blood test that you don't need any special fasting requirements to have done. It is a simple test that's widely available, and it basically tells you how at risk you are for prostate cancer based on a number. There are different cutoffs. The most common cutoff you hear is number of 4. So if your number is between 0 and 4, you could be considered in a relatively safe zone, okay? But that's not the only factor, okay? You can have prostate cancer with a PSA of 2. You can have a PSA of 20 and not have prostate cancer. Dr. Hoffman and I have seen both cases many times. So it is not a perfect test. So we use other things in addition to PSA to screen men for prostate cancer, including, very importantly, and unfortunately somewhat going by the wayside, the rectal exam. The rectal exam, where you actually palpate, meaning touch the prostate and feel for bumps and lumps, is crucial to screen men for prostate cancer. But in addition to that, simply looking at the PSA trend over time, meaning is the PSA rising, and if so, is it rising quickly? Something called a PSA doubling time. How quickly does the PSA double in its value? PSA density. What is the amount of PSA per gram of prostate tissue that you have? These are important. Now, there are other tests that have come into play recently, something called 4K score, prostate health index. These are other blood tests which can be used to help guide decisions. And the ultimate question you're going to have is, do you need a prostate biopsy? And that sounds like an easy question. Well, if there's a concern for prostate cancer, just do a biopsy. It's not that straightforward, actually, for 2 reasons. Number one, there is potential for side effects from the biopsy, okay, including bleeding, but more importantly, infection. There is a small but not insignificant risk of getting a severe infection from a prostate biopsy. The other problem with the biopsy is you might detect or over-detect prostate cancer. So perhaps Dr. Hoffman can talk about this, but basically what we found, now the pendulum had swung the other way, where we were detecting too many men with early stage, non-aggressive type of prostate cancer. And it seems that too many men were being treated for this type of prostate cancer. and that had led to changes in national recommendations for screening, and that actually, as a result, led to the pendulum swinging back to now more and more men, unfortunately, not being screened and presenting late. Dr. Hoffman, has that been your experience?
It's been mixed. I think, there's definitely been a swinging of the pendulum, so to speak, but still, thankfully, most people are diagnosed early. I think that, but definitely it's hard, I think it's hard really to completely see whether or not the diminish in screening has clearly led to people presenting with advanced disease. I think we've certainly seen some examples of that, but I do thankfully think that we're still most of the cases we're catching early. I think in the ones that weren't going to get screened and the cancer wasn't going to be aggressive, you kind of don't know what you don't know. If a guy wasn't getting his PSA checked and he maybe has prostate cancer, but the prostate cancer that he has is a non-aggressive variant that's never going to impact his quality of life, and he continues not to get screened, then you didn't find anything that wasn't a problem. It's all about trying to, the word cancer, and I think that Tom obviously can speak to this very well as well. The word cancer and it carries with it tremendous significance in how patients think about their future prognosis, but that word itself, is perhaps overused in a lot of different aspects, and by calling something cancer, automatically somebody's going to think that at some point this specific finding is going to place my life and my quality of life in jeopardy, when if only 1 of 8 men are passed from the prostate cancer, it didn't really, in those brief statistics, tell us how many of those men were successfully treated for their prostate cancer and therefore avoided succumbing to the prostate cancer. So it gets confusing. I think the most important thing is to understand your specifics and not to get too worked up over words. It's, and the word cancer, there are, and you have to look at the big picture. You have to look at a patient's age. You have to look at their other comorbid conditions. When somebody who's 79 and still smoking cigarettes and had a heart attack and a cardiac stent, if their primary is still checking their PSA, or let's say not even say 79, call that person 71 or call that person 68. A 68-year-old who's smoking and had a heart attack and is overweight and has a little diabetes, and then all of a sudden finds out that his PSA is 4.4 on some random screening, and then he finds out he's got a little prostate cancer. We did a biopsy. If you look at that person in the big picture, what's the likelihood that prostate cancer that was found for the PSA that was only marginally elevated is really going to have a negative impact on that person's length of life or quality of life? And so, you encounter patients who, are referred to you often, who are referred strictly based upon that number and to work up the number, and you realize that what you're really trying to do is not just, treat a patient in a bubble and only look at your specific disease process that you're supposed to talk to them about, but you really have to, assess a patient as a whole and try to prioritize, where it's best to, invest your time and your medical resources in trying to decrease morbidity and improve quality of life. And the PSA has been helpful that it's picked up prostate cancers early, but it truly has created a big quandary and trouble in our healthcare system, where patients are getting treated for something that they truly don't need to get treated for. And, the word cancer and calling something cancer that's never going to impact somebody's life negatively, it's a challenging scenario to kind of, walk that back a little bit. And there's a lot, and those are some of the things that I think are important to kind of, take note. I think to answer Tom's question, I think that, when you had, what is PSA, we went back and you were asked, what is PSA, just to kind of further clear that up. PSA is just an enzyme. It's made in the prostate. Every single prostate makes PSA. right? Every single prostate makes PSA. And as your prostate naturally gets larger as you get older, your PSA naturally goes up. So some men have bigger prostates than other men. So some man, a PSA that's 4.5 will be completely normal, as you were saying, while another man's prostate, the PSA will be 4.5, will be, potentially a problem. And so, I think, that's really what I wanted to say about that.
No, this is great. This is great stuff. And to Sam's point, for you men who go out and get your screening and get your PSA, say from your primary care doctor, and say that number is 15, I think what these gentlemen are saying is don't go jump off the Newburgh Beacon Bridge. Your PSA could be elevated for many other reasons other than prostate cancer. Sam, can you add to that?
Yeah, I want to echo what Dr. Hoffman said, that it's important not to look at the patient in a bubble or just as one number. You want to take into account their comorbidities, their age, their desires. If they tell you that even if I'm diagnosed with prostate cancer, I'm not going to want treatment, then I don't think it's a person that should be screened. On the flip side of the coin, I don't want people to go towards the opposite end of the spectrum too much and think that there is, little or no benefit to continuing with prostate cancer screenings. There has been an uptick in presentations of patients with metastatic disease from prostate cancer in recent years, which could be correlated to the decreased use of PSA. It's not a causality, but there's, that's not been proven, but we certainly have seen that in recent years. As PSA has been used less, more men have presented with prostate cancer already far gone outside the prostate, and at that point the horse has sort of left the barn. But generally speaking, PSA is an imperfect screening tool. We don't have a perfect screening tool. It doesn't exist for prostate cancer. We have other tools in our tool bag now. More recently, we've added MRI prostate, which we can actually dedicate an entire podcast to, which has been.
Yeah, we will do that actually with you guys.
Okay.
Yep.
Okay.
Yeah. But I was going to say that, so what I'm hearing, and again, we're going to actually put a face to this, is that a man comes into a primary care physician, he's 40 years old, gets a PSA, gets a 4.5, starts freaking out, gets referred to you guys. You guys are not going to look at that guy as a 4.5. You're going to look at him as a 40-year-old gentleman. You're going to ask him about his urinary habits. You're going to ask him about his erectile function. You're going to do all of your indices and all of your quality scores, and you're going to examine that patient. Let's take now that PSA level, and now you have your finger is doing a palpation of the prostate, which, guys, it's not fun, but it's necessary. And if you don't have a rectal examination by your primary care docs, you're getting gypped. You really do need that. And your urologist is an important person once you start hitting 40 and you start noticing some changes in your urinary habits, your erectile function. These are the guys that really know what's going on. So together, gentlemen, Mike, I'll ask you this. PSA level, mildly elevated. You do a rectal examination, you find an enlarged gland, but you don't feel any sort of what we call in the business nodules or any hardness or firmness. You're able to put your finger around the sides of the prostate. Your worry level on this guy is probably very low.
Well, you said 40.
40-year-old guy.
40-year-old guy and a PSA of 4.5.
Right.
So just
with an enlarged prostate.
Right. So most times 40-year-olds don't have enlarged prostates, right? Enlarged prostates are when somebody's older, in their 60s or late 50s. Some men in their 40s will have an enlarged prostate, but generally a PSA of 4.5 in somebody who's 40, and the screening recommendations for whom to start screening, if you have a family history, then you would perhaps get screened at 40, but currently the recommendations are one time in your late 40s and then annually 54 and older through the age of 69 to get your PSA annually. So the 40-year-olds generally, unless you have a strong family history, we wouldn't be screening, we wouldn't be sending off a PSA. One thing which we didn't mention is that the PSA is this enzyme made in the prostate. But let's say you went on a long bike ride or you had sex. Apparently, it's been said sometimes it may influence, sometimes it doesn't. Let's say you went on a long motorcycle ride, you went on a long bike ride, you had a cold, you had a little inflammation, you had a little bit of irritation. There are a multitude of things that you can pinpoint about a patient's history and some things that you just frankly can't pinpoint about a patient's proximal history that can falsely elevate the PSA, right? So if a 40-year-old, we would assume that that first number is going to be 4.5 with that 40-year-old because he probably wasn't screened before. So that 40-year-old probably is too early to be screened. If let's say that we say that make that patient, let's take that 40-year-old patient and make that patient 50, okay? Let's take that 40-year-old, make that patient 50. And let's say one time his PSA was checked before that. Is this the first PSA check that you had? If it was your first PSA check and it was a 4.5 and we don't know what your PSA was before and we see the urine analysis doesn't reveal anything with infections and you don't have any, then all I would do is say we're going to check that number again in a couple of months. And you'd be surprised as to what percent, I would say the percent of patients who have a slightly elevated PSA and that then returns to a normal level with zero manipulation, zero treatment with antibiotics. When I was in training, one of my physicians I was training under, when we started to use PSA more, he would, knee jerk every single time somebody had an elevated PSA, they automatically got 2 weeks of antibiotics for the possible case of asymptomatic infection in the prostate in order to try to lower the PSA in order to see what it really is. Indiscriminate usage of antibiotics is a whole other conversation and something that we certainly shy away from, and I certainly shy away from. So treating a person who's 50 or 45 and comes in with a PSA of 4.5 and without any other infectious symptoms, they're not getting antibiotics from me, but they're going to be calmed down and we're going to recheck. And you'd be surprised. I would say that 40-year-old, if it got checked and it was 4.5, I would say the chances that his PSA number is going to be less than 2 when we recheck it 2 months from now. And it takes about a month for it to settle down. So let's say if we give it 2 months and we recheck the PSA, I would say just right off just from my past experience, the chance that 4.5 is going to be less than 2 months from now and may in the normal zone is greater than 50%, right? So I would...
But I want to just jump in there. But
Please.
If you repeat it,
Yes.
and it's 4.5 in a 40-year-old, I'm worried.
Yes, absolutely. So I think that, again, the size, you say it's an enlarged prostate, you're not so worried. When you kind of alluded to, you're not so worried about that PSA of 4.5 because he's got an enlarged prostate, right? I wouldn't be too worried about a PSA of 4.5 in a guy who's 65 if he has an enlarged prostate. But the 40-year-old is very unlikely to have an enlarged prostate big enough to naturally explain, as Sam was talking about, this PSA density. How big is your prostate? Bigger prostates, making more PSA, what's normal for you is higher than normal. So without having any ability to assess the rate of change, I wouldn't assume that it was such a big prostate. And in that specific patient, I would just try to calm that person down and recheck it in 2 months. If it comes back the same way elevated, then indeed it may be something that we need to be concerned about, especially if that person had a family history of early on prostate cancer in the family. And at that point, we would move further on. We would perhaps get an MRI, or most likely get an MRI to try to if the exam was normal, can we pinpoint any area within the prostate that appears to be suspicious for a cancerous focus within the prostate that we're not able to feel on the exam? Because the vast majority of the time, we're not able to feel something on the exam. Probably 85% of the time, patients who come in with an elevated PSA, we're not able to feel anything abnormal on the exam. Something like that, maybe 75, 85%. But the times when you do feel something on the exam, there's certain moments when you say that because the PSA is imperfect, you may have cancer. quite bad. There's the more aggressive variants of prostate cancer, they don't even raise the PSA. So you might have somebody who comes in with a relatively normal PSA, but they got really, really bad prostate cancer because their prostate feels like a rock, and then they have significant urinary symptoms. So it's a very confusing thing when you think like, oh, this is a screening test and it's used to screen for cancer, but it's an exceedingly imperfect screening test. But unfortunately, we don't have a better screening test. So the tools that we have at our disposal, the MRI, and now that being more measured with our decisions as opposed to like every cancer needs the book thrown at it. Can we wait and see? Can we follow? Can we decide how aggressive we need to be? There's a lot that goes into the, how you manage and what makes the most sense on how to.
Yeah, no,
treat
this information is tremendous, and I'll tell you what I gather from this. For the gentlemen and the survivors listening today, this is not a easy subject. When we talk about PSA and we talk about prostate health and we talk about screening for prostate cancer, as you can tell from this discussion, it is a multifactorial, multi-dimensional situation. And Sam, I was going to ask you, because last week the listeners got to be a fly on the wall of my colonoscopy. So give me a fly on the wall for a gentleman's prostate biopsy.
That was a video podcast or strictly audio?
It was completely. It was live. It was streamed. It went viral. TMZ has it up if you guys want to check it out. Yeah.
Well, that's one nice colon. Wow.
Sure, Tom. So I'll tell you, there's actually, and I just had this conversation with the patient not 1 hour ago, but there's many different ways that we can actually do a prostate biopsy now. Up until a few years ago, the standard way was you have a patient come to the office, they have a preparation consisting of an enema, some antibiotics, they lie on their side, and we put in an ultrasound probe, which is the size of a finger. We take some pictures of the prostate just to get a general sense of its shape and its size. Very rarely do we actually see prostate cancer on an ultrasound. That is the exception, not the rule. So what the ultrasound is then used for is, after you numb the prostate, is used to guide systematically a needle to all the different areas of the prostate to try to sample the entire gland as accurately as possible. Occasionally you will see an area which looks abnormal, which you may focus in on, but that is not the way ultrasound usually goes. Contrast that to today, where we have now the ability to get an MRI before a biopsy. The MRI is much more accurate at actually visualizing prostate cancer lesions. And what you can do is actually take that image from the MRI and put it on your ultrasound screen. So while you're looking at the prostate with the ultrasound, your MRI fusion is there with the MRI images fused there, and it's moving with the ultrasound. And you can more reliably and precisely target a spot that might be concerning for prostate cancer. That doesn't mean that we only target the spots that are concerning on MRI. We go ahead and get an entire biopsy of the entire gland as well, like we would in the past.
I think it's called the 12-quadrant biopsy. Is that kind of what you guys do?
Yeah, that's right.
6 quadrants, 12 biopsies.
12 biopsies, 6 quadrants,
right.
Yes.
Yeah. So,
what's the sensitivity and specificity of those 12 cores?
Are you talking about with the fusion or
yes,
without the fusion?
With the fusion.
So the way to know the sensitivity is you have to compare it to a gold standard test.
Correct.
The gold standard test would be a saturation biopsy of the prostate, where you literally take 40 pieces, of the prostate or more. And in fact, people have called it a
needle prostatectomy. I bet, yeah.
So, if you look at the standard ultrasound biopsy alone, it's probably around 50 to 60%.
What is the
transrectal ultrasound?
The sensitivity or the specificity?
Sensitivity.
So that it's meaning what?
Meaning that there are 40% of cancers,
60%,
Gleason
right.
6, you may not catch with this. Okay, if you look at MR fusion biopsy, where let's say you're targeting just the lesion,
Yes.
you're probably up to 70%.
Right.
But when you add the two, meaning the systematic biopsy plus the MR fusion, you're looking at 80% sensitivity.
Is that now the standard for prostate biopsies in the country?
I wouldn't say so, because it's an expensive technology. And so not every facility has access to it. We are fortunate enough to have access to number one, you need a good MRI machine.
Yes.
Number two, you need a radiologist that's capable of reading prostate MRI as well, and we have that.
We absolutely do, yeah.
And number three, you need the fusion software and machine as well. So we have all those things. We've been able to do it here for the past year. We've had some good results. Dr. Hoffman, I think you had a patient recently that...
I'm still a little confused as to those numbers a little bit. Sorry to go back. I mean, I think that, 60%, 50% sensitivity on a...
50 to 60%.
50-60%, and then 80% with the MR fusion. So that means that, flipping that around, that even by doing the MR fusion, there's a 20% chance that we're missing cancer.
Correct.
That's there.
Correct.
Right.
Because there's Gleason 6 cancer, which will not necessarily be visible on MRI.
Right.
If you're
Usually,
doing-
I thought that it was the more aggressive, diffuse ones that were the Gleason, the high ones, the cribiform, like
Those are
right,
pattern 4
right.
cribiform are sometimes not visible, but some pattern 3s are,
Yeah.
which are clinically not significant, are also not necessarily
I think when you're
visible.
talking about the sensitivity of the exam and everything like that, I think what you're kind of really driving at is that, I'm a man. I'm here, I'm trying to figure out, there's risk attached to having a prostate biopsy, right? So I'm going to accept the risk of having a prostate biopsy. I'm going to accept the risk of potentially dealing with an infection. I'm going to take time out of my life. I'm going to have this procedure, and I'm going to open up a potential Pandora's box of what's it going to be for me in the future, and what am I going to have to deal with now. And so you have this test, and then you end up, if the test comes back with cancer, then you're hoping that that was as like an accurate description of what indeed is going on. You may find cancer, but there may be more aggressive variants of the prostate cancer just alongside of that. That's one angle, but the more real reason that we're bringing this new technology, the MRI on, and the MR fusion biopsy that Sam was talking about, and we do have excellent examples, is ultimately to drive up that sensitivity, to catch what is there. So, if you're going to accept the risk of having a biopsy, then you want to, and let's say, because this is what happens a lot of times. You have a guy, let's say that 50-year-old guy, okay? Again, that 50-year-old guy with the PSA of 4.5. Okay, we did a biopsy on that guy before the advent of MRI. Okay, so this guy has a PSA of 4.5. Let's assume that some people, they were just like, oh, your PSA is 4.5, you need a biopsy. There were some people who practice like that. There are some people who would be a little more conservative with their approach and say, let's wait a couple of months, see if the PSA is still elevated. Let's say you wait a couple of months, and like you said, oh, you're not too worried about it. He's got a big prostate. Well, that's nice to say, but we can't really assume that. Let's say, next year the guy's got a big prostate. So the guy's got a big prostate. He said, I got a big prostate. Oh, wait, 4.5. Next year that guy's prostate, his PSA is going to be 5. It's not going to all of a sudden go to 3 or go to 2. If you're really thinking that his PSA is 4.5 is normal for this person, then it's normally going to continue to go up. And if that person is young, right, 50 is young, 40 is super young, right? 50 is super young too when it comes to prostate cancer. If you're contemplating biopsying somebody's prostate for a PSA of 4.5, 5 for a patient who's on the younger end of the spectrum, then the likelihood that moving forward in the next few years, let's say, you did a biopsy for a guy with a PSA of 5. The biopsy comes back with no cancer. You say the guy's super happy. And they'll say everything went smooth, right? The guy's happy. I don't have prostate cancer. You just have an elevated PSA. Oh, you have a big prostate. Okay. All right, good. Okay, good. So the next year the guy gets another PSA, either from us or the primary, and maybe the PSA now is 5. The PSA is 5.2. It was 4.5. Now it's 5. Now it's 5.2. You're like, oh man, my PSA is going up. And then ultimately what you're worried about in that situation is
That you missed something.
that did we
Yeah.
have a false
Right.
negative
Right.
prostate biopsy? Because before the advent of the MRI and before the advent of using the visualization in advance of a prostate biopsy, you encountered patients who have had one biopsy after another biopsy. Oh, your PSA is 5, maybe we won't do anything, but next year it's 6. One of my biggest referring primary physicians here started to send me, a large bulk of his patients because, he had a physician who was about to offer up the 4th prostate biopsy on a person whose PSA was only, climbing at a very mild rate, and he had 3 negative prostate biopsies. And so, when is enough prostate biopsies?
Mike, I'm going to tell you
Yeah.
exactly, because listen, CROC Nation, I don't know about you guys, but you two guys are going to get one shot at me. So it better be good, because I'm going to only let you put that needle in me once. So give me an MRI, give me a Dr. Bones Star Trek fusion scan, whatever you have to do. Make sure you give me the information, because I only want to get it done once. So let me ask you guys this. For this podcast, again, we're for John Q Public. One of the things you're going to want to know is, hey, if we do have to get screened, we do the rectal exam, we do the PSA, there's an abnormality. My urologist asked me all the right questions. They asked me my sexual inventory, my peeing inventory. They asked me about my history, my family history, genetics, all this kind of stuff. And everyone is in agreement. There's an abnormality on digital. There's an abnormality on blood. You have to have the prostate biopsied. They're going to want to know from you guys, does this hurt? That's one of the things they're going to want to know. So tell me about the process of the biopsy from the patient's perspective.
I will tell you, so this was looked at in a study when I was a fellow. And we asked patients to rate their discomfort from the procedure. And looking at actually the needle going in through the rectum, you would think, boy, that sounds painful. But actually, for the vast majority, it is not painful, okay? Some people do have some discomfort. We can give more numbing medicine. Not to say that everybody's going to have a pleasant experience. It's uncomfortable. But my experience has been it is well tolerated. The discomfort usually happens later on in the day or the following day. And it's usually something that's probably sounds worse than it actually is. I've not had one done myself, but that's the feedback I get.
Mike, you too?
So perhaps a little, I as a physician, right, what I feel like, what really, what you take home with you at the end of the day, you take home the case of the patient who left unhappy, right? You, as a general rule, you see lots of patients. You try to do your best by all those patients. And the vast majority of those experiences are very quality experiences back and forth. They're happy with your service. You're happy with how they approached you. But ultimately, the nature of the business of dealing with people in stressful, potentially painful situations is that it's not always going to go smooth, right? You're going to have situations that are not smooth. And those not smooth situations are the ones that, at least for me personally, are the ones that kind of rattle around in my head more than the smooth ones when I'm sitting alone, at home.
Yeah, that's just the way we work in medicine. I agree with you 1,000,000%. But in your experience,
so in my experience,
yeah.
so in my experience, it's very well tolerated.
Mm-hmm.
But because it's not entirely predictable which patient is going to have a absolutely smooth experience and which patient is going to have a less smooth experience, that I have started to, for pretty much all of my prostate biopsy patients, although it adds a cost, and that's something that you have to be upfront about, I have started to have them be sedated for the prostate biopsy. A little bit of colonoscopy type sedation. I have
Happy juice, Angel.
Yeah, I'm over here in pain just thinking about
No,
it.
yeah.
But not as an outsider, just to come in real quick. I agree with what both of you say. It's not a pleasant experience because your mind takes over first, right? As a patient, the first thing I think about is that needle is going in. But as a person who've had many kidney stone surgeries and I've had a lot of stents, after a couple, you realize what is going to happen. You don't feel it. You just gotta.
The fear of the unknown,
Yes,
the stress that when you're stressed, when the cortisol is up, when you're in an anxious state, how you perceive pain, how you deal with stressful moments, especially in your private area, those are very much issues that we have to contend with as urologists. And also now with our advance in the technology of the MR fusion, where we're using MRI images, we're really trying to target specific areas. The MR fusion only can be done on a specific table that's only available in our operating room. So as we are shifting to more targeted prostate biopsies, we're generally doing them in the operating room. You don't fully have to be put to sleep, but you're made comfortable. And I have not had any, I told patients I would do 10 prostate biopsies. 7 guys would tell me, I used to say, 7 guys would say, it was fine. It wasn't my best day in my life, but it was fine. And, I got through it just fine. 3 were like, I didn't really, let's say, so 6 guys said it was fine. I made through it just fine. Everything's fine. Thank you, doctor. 3 were like, thank you, doctor, but I'd rather not do that again, right? And 1 guy was like, would potentially be thinking that I did them a disservice, was angry at me, was, maybe not 1 out of 10, maybe 1 out of 20, but there were those random people who had such a negative experience that, dealing with them while they were awake and, to me, maybe I overplay it a little bit. I want to avoid those ultimate negative experiences. So, I work in a hospital here where it's very easy to, manipulate my schedule and have patients done, with a bit of sedation. And I have yet to encounter a man when you tell them, you have insurance, and I'll do the prostate biopsy when you're a little sedated. But if you want to do it in the office, we could just do it in the office, right? And just
how
give you a little
many people out of 10 are going to be?
There's not too many men that are not wanting the sedation.
Sam, as we wind up this podcast, I did want to end with one really important point, and I want you to address it. Women are great advocates for themselves. God bless them, and I think that's great. So breast cancer, the pink movement, God bless. I love it. I'm part of it. I couldn't not say any more positive things for the ladies out there who are trying to get resources for their breast cancer, trying to get information, trying to help each other, trying to be vocal about their breast cancer or whatever. With men, we don't really see that. And I was hoping that we went through a lot of material today, way more than I thought we'd get to. We talked about the multifactorial aspect of prostate cancer screening. We talked about the imperfections. We sort of took the veil off of that. We kind of broke down that fourth wall for you guys about what's really going on behind the scenes of these prostate cancer surveillance. What really is the value of the PSA if it's not interpreted correctly? What are some of the other factors that are in play? And we're going to end with asking Sam about men's basically disinclination to advocate for themselves, to seek help for themselves, to get treatment for themselves, to be screened for their own issues, if you don't mind.
I think you raise a great point. And this sort of goes back to the phenomenon that we've seen where people show up to the office saying they've lost weight, they're having tremendous trouble urinating. You check their prostate, it's like a rock. Their PSA is 600, through the roof, and you find that the horse has left the barn with regards to their prostate cancer. Then you ask, why is it that you never got screened? Why, without trying to make them feel badly about it. And you'll hear oftentimes, well, it wasn't offered, which is unfortunate, but you might often hear that, I didn't want to pay the copay, or I didn't have time to go to the doctor, or so men, as men and as fathers and as brothers and sons, we have a natural inclination to provide. to work and provide for our families, and sometimes at the detriment to our own health. So, Tom, what I would say to your listeners is don't neglect your health. Don't be stubborn. Let your family take care of you. Listen to your loved ones. Listen to your wife. Come see us. Come see your primary care doctor. There's nothing to be worried about. There are many, many different ways of treating prostate cancer. Hopefully you don't have prostate cancer, but if you do, we will take good care of you.
Beautiful. Guys, I could not have asked for more. The amount of substance of this podcast is indescribable. The amount of information you guys have provided us, also indescribable. Your professionalism, I told all the listeners what skilled surgeons you are, what gentlemen you are, and we are very humble and very grateful to have you today. I would like to ask that you guys come back, because you also opened up many other questions and many different avenues that we haven't addressed, which we do need to address for men's health, men's cancer health issues like bladder cancer, blood in the urine, prostate cancer treatments and things like that, health disparities, men of color who have a higher incidence of more aggressive prostate cancer, many, many things to discuss. But for today, we're going to end this podcast as we end all of our podcasts. A great shout out to my friend Angel Santana. Angel, thank you.
I just want to say he's hired. They're both hired.
They've been hired. They're amazing. They're on retainer.
I'm ready.
Yep. I'd like to thank Rod Freeman, Small Biz Up, Michael J. Benzea, Charlotte Larson, our beautiful sponsors and patrons. And last but not least, I leave you, CROC Nation, as I will leave you at the end of every podcast. We all, on behalf of Dr. Hoffman, Dr. Abourbih, and Professor Angel Santana, we wish you a long, healthy, happy, and cancer-free life. Peace until next time.